Okay, hello everybody and welcome. I'm very delighted to open the ISSM webinar today. We're excited to host a world-renowned faculty today on ISSM webinar. The title today is Penile and Urinary Prosthesis Simulation. This webinar will be presented by two speakers, and we have Dr. David Ralph, who are going to introduce the speakers. My name is Dr. Omar Rahim. I'm a urologist at the University of Chicago and also the ISSM webinar series chair. The ISSM made an effort really to introduce really a newer features on Zoom to allow our audience and listeners to use the knowledge we are providing on this webinar and others using the translation features through Zoom. So please choose your own language through the caption from the bottom of the Zoom, and we'll be able to translate into your own language of choice. The International Society of Sexual Medicine main vision is because every human being has the right to a healthy and satisfying sexual life. Next slide. The ISSM really has been founded since 1978 and founded its mission, which focuses on the entire field of human sexuality. The main mission of ISSM and purpose is to become the most respectful and trustworthy source for information, education, and professional development in the field of human sexual health. We've achieved this through a delivery of world-class publications, webinars, research findings, and both online and in-person activities for dissemination of knowledge and exchange worldwide. ISSM has 7 regional affiliation of sexual societies as represented here across the world, including also the International Society of Women Health, of Sexual Women Health as well, which has been a member as well of the ISSM. ISSM has also a mission to really promote the knowledge and sexual health through different platforms, the ISSM official journals, the Journal of Sexual Medicine. Also, we have the Sexual Medicine Open Access. We have Sexual Medicine Reviews, who has just been given a new editor-in-chief, Dr. Giraldi, and wish her the best of luck. We also have refurbished the Video Journal of Sexual Medicine, recently accepting a lot of sexual and surgical videos on this platform as well. So without further ado, I'd like to welcome Mr. David Ralph, who needs no introduction. Mr. Ralph has been speaker, faculty, and moderator for many, many ISSM webinars. But briefly, he is the past president of the British Association of Urological Surgeons, Sexual and Urology. He's past president of British Society of Sexual Medicine, the European Society of Sexual Medicine as well, the ISSM, and he's currently the chairman of the European Society of GU Reconstructive Surgeons and the president of the Sexual Advice Association Charity. So without further ado, Mr. Ralph, please take it away, and look forward to a wonderful webinar today. Thank you.
Thank you. Thank you very much, Omar. Hope you can all hear me. We have the next slide, please. So we have quite an exciting program today. I think, I mean, you've just heard Omar talking about education. Well, this topic really is about education, and particularly for surgeons. So, you know, you will actually practice and know how to do these procedures before you actually get loose on the patient. So it's patient safety as well. But of course, I think I've actually been involved in some of these, and it's really exciting. So I'm looking forward to the talks tonight. We have two speakers. Ahmed Ghazi, who I know very well, is going to talk about the penile implants and the artificial sphincters simulation, and that's going to be absolutely fantastic. He's from Johns Hopkins. And then we've got some Peroni's printing advancement as well. I deal a lot in this, so I'm very pleased to be able to chair this. And this is Bruno Macheo from the University of Arkansas. Next slide, please. Now, please, we're going to have the Q&A at the end. So both speakers are going to give their talks, and then you can put your questions in the Q&A as we go along, and then I'll sift through them, and then we can ask the speakers the relevant questions at the end. So don't put it in the chat, put it in the Q&A, preferably with your name as well, so that we can refer to it. Next, please. Okay, so without further ado, Ahmed, do you want to take us away?
Yes, David, thank you very much for the very kind introduction. It's truly an honor to be here with yourself, Dr. Rahimi, as well as newly introduced colleague Bruno. Very excited to hear his talk also. I'm going to be talking really about the capability of producing hydrogel realistic models for surgical training. And part of this talk is really going to explain the process of validation that we went through for this. Next slide. So no disclosures here. Next slide. So this is development of a non-biohazardous hydrogel model for penile prosthetics. Next slide. So the way that we developed this was really through a very educational platform. So I have a master's in education, and the way that we have developed the development of this model was really going through a very scientific approach. And we've published this. So for example, we need to understand from experts like David and Omar and Bruno, what really does the expert require to be placed in an ideal simulation model? So we do a hierarchical task analysis, and then we take all the contents of those hierarchical task analysis and put it through a Delphi process, which is a consensus building process. We then take all that they gave us from that and translate that in my lab at Johns Hopkins into what we call engineering deliverables, translating the physician's requirements to engineering tasks. Then we develop a prototype that goes through a significant amount of iterative prototyping process. About 10 versions of these models are done. Experts try them. I remember flying down to the UK and actually having Dr. Ralph try the first couple of prototypes and give me feedback on it. Then we change and make the modifications, and accordingly, we then end up with a final model that we actually validate. Next slide. So these are the experts that were involved in validating the penile prosthesis model. As you can see, we have an international group of experts, some of them also local, that allows us to really encompass what is required from this model. Next. So here's an example of the hierarchical task analysis, right? This is the publication that we have. Basically, we tell the surgeons, give us what you think from a stepwise process of each step of the procedure. What are the anatomical landmarks? What are the step-by-step substats? What instruments we need? And what are the errors that potentially could happen during each step? Next. And this is a CAD, a virtual model that we design in the lab using CAD software that we then show to the experts, and then they give us feedback on sizes, girth, locations, anatomical, et cetera, et cetera. Next. We then take all what they gave us and turn it into engineering deliverables. For example, the urethra, anatomical relevance must run in a certain anatomical location. It should have tensile strength to be able to pass a catheter, but also to hold sutures and also get injured during cautery, for example. Next. Here is a video, very short video of the actual simulation itself of the final prototype. And you can see here, we have simulated the procedure all the way from the beginning of the actual incision, all the way down to the final part, including errors. So here you can see, this is really just brushing away some of that fibrofatty subcutaneous fat, dartos fat, and then putting in the stay sutures that you're accustomed to be placed in. Then after that, making an incision. Now, most of our models bleed, but here we didn't want it to actually bleed. So what we did is we added this like paste-like substance inside that would allow the surgeon or the trainee to know that they're in the corpora, and also do subtle things like cutting from, above down so that they don't get blinded by the blood that's coming out. This is the dilatation. You can perforate here, as you will see later in the video. And all the steps that are required and all the simple tasks and substeps that are required for you to do this and the tips and tricks are needed in this model. You actually use the set that you would utilize in the actual operating room. All the steps encompassed, for example, placing the reservoir. You can place an ectopic reservoir here also. This is an anatomical model. It's not a model that is made specifically for a certain approach or a certain procedure. It is basically an anatomical model that you can utilize with whatever approach you want, right? So they pass the guide sutures, as you can see here. Then we're going to place the penile prosthesis at the end. And you can also place the actual device in the scrotum that allows you to control the penile prosthesis. So we've really thought about every single step that is required, and that's why it takes such a long process for us to do this prototyping. And whenever feedback we get, I would say we're still really improving parts of the model, although as you will see in our publication, it is quite significantly validated, but we still strive to improve more. Focus on creating a subdartos layer where you can actually place the scrotal pump was also very important. And then finally, being able to look at the errors, which is a very, very important component of really being able to add this model here. So you close the skin at the end like normally you would close any real case that you do in the operating room. And then you can actually test your prosthesis to see how things are and see what the erection is like, see if you did any shortening, see if the cylinder on one side has perforated and therefore it's not erecting. So this is an example of the actual prosthesis, being tested. And then we'll show you a series of errors that we've instilled in the model itself. So you can see that you can perforate the corpora. We took a lot of testing to make sure that it wasn't too flimsy, and so it's not perforating with low pressure. We placed iliac vessels there in case you're placing an ectopic reservoir, and so you can see if you've injured the vessels. And then finally, if you had a urethral injury. Next slide. So this is just the validation, the face validation, really telling us whether our model was realistic or not. And we send this out to 150 participants. Next slide. You'll see that these are the components that they felt very strongly resembled real life surgery. Next slide. And these are the parts that really were not as good as we imagined they would, and we needed to modify. Next slide. Again, we wanted to ask them the value of the simulator itself. You can see the non-biohazardous nature. Some of these expert physicians did it in their office on their desk. So that's how valuable that is. And also the fact that we can replicate pathology is also there. Next. The good thing that experts, we asked them, how many models do you think it would be ideal for a trainee to do prior to actually engaging in live surgery? And they said it was an average of about 3.5 models prior to live surgery. Next slide. Next slide. So evaluating this as an alternative simulation platform for penile prosthesis prosthetic surgery. So we wanted to compare this to cadavers. So this was really taking it to the maximal level of validation. Luckily, we had a grant from one of the industry companies where we got 88 participants. We had them do both the model and live surgery of the cadaver and then compare both of them. We randomized which one they start with first, and we asked them 3 questions regarding realism, procedural steps, and education like that. Next. Here, as you can see, the workshops that we did this, it was a 2-to-1 trainee to model ratio, and then we randomized who started first. The experts had specialized sessions where they were only one-on-one with the model, and we got feedback at the end of the course. Next slide. Here you can see just that we published this paper. You can see that there's a significant amount of resemblance between the cadaver, which is the gold standard, and our model, meaning it can replace it. And these are the steps that we felt were the most valuable from the skin incision all the way to the reservoir placement. Next. Here we found that they felt that improving technical skills, using it as a teaching tool, but more importantly, using it as an evaluation tool, all graded very high. 67% of experts, and I'm very proud of this, believe that the hydrogel model was the same, if not better than cadavers for training, and 79% felt it was actually safer than cadavers. Next slide. Next slide. So we wanted to expand things a little bit. We wanted to look at the possibility of remote training. So it was during COVID, and what we did is all these trainees got an instructional manual and this narrated video. Next slide.
So now I want you to take the scissor, and if
So
you
this
look at
is an
my hand here,
example
you're going to go
of
down
me
straight, and then you're gonna
guiding
open
a
up the scissors
trainee
to
that
widen
is
up.
in a totally different
Very
building
good. Again, use
using
your
a
right hand
combination of
to
mixed reality.
stabilize the tissue while you're doing that.
So we get these Vuzix or Google
Directly
glasses,
in, and then just
and you
spread
can see, he can see an overlay
Yep,
of
there
my
we go.
hand
Spread the
in
tissue
his
all the way.
point of
Very
view.
good.
So he's
Now you're
able
gonna
to
grab your
actually
dilator.
follow my instructions step by
Beautiful
step.
tool right here. So now what you're going to grab it with your fingers, right? Right there.
So you
That's
see
how
how
you
I'm telling
grab
him to just overlay the instrument on my instrument?
So
That
you
view
get your
is showing in his
fingers
point
here,
of view through
your
the
middle
camera.
and index, put them underneath, and then wrap it with the thumb.
Next
This
slide.
is where the sensitive part.
So
You're
this
gonna
was a
bring your
very
hand
unique way.
down.
Oh, sorry, one more slide.
The incision is going to be right across the top.
This
right
is
over
now
the-
not building to building. This is
Right here.
state to state.
People sort of
This is
jump
New
a little
York
bit
to
lower.
Vermont. And you can see that we changed the color of the
Yeah.
gloves for the proctor and for the trainee because
Yeah,
people were getting
probably.
mixed up.
Yeah.
They were thinking that was their
Right,
hand.
right.
So you see the proctor is in a totally different state. And what they're doing is they are trying
Make
to
it bigger?
guide them through what they need to do.
Longer?
The model is
Make it wider,
non-biohazardous,
smaller?
so it could be in a resident room or on the desk in an office or whatever you need. And you can train using this relatively cheap way to train. Next slide.
Okay, now take a deaver and hook this.
Next
and
slide.
pull it up.
It's the same concept. This is now our AUS model. We're presenting this at the AUA. This is our newly model where we actually developed our own model for artificial urinary sphincter. Dr. Rahimi was one of the first people to actually try the first prototype at one of the international conferences. We were there together. So it was very inspiring for him to do that. But you can see we've replicated all the steps of the procedure. We've made it into somewhat of a different model, separate from the penile prosthesis model, although we can bring them together. And we were keen to allow you to place the reservoir, allow you to place the pump. We even created part of the anterior abdominal wall. Next slide. So the future of this is what we imagine is really being able to use these non-biohazardous models in the hopes that we can democratize training using either in-person or remote training using this very simple mixed reality technology that we've developed in the lab. Thank you.
Well, my name is Bruno Machado. I work at the University of Arkansas for Medical Sciences. I will be not as fancy as Dr. Ahmed because my goal here is to create a low-cost model. And although Dr. Ahmed model, it's cheaper than have a cadaver, mine is, the idea is to create a low fidelity model so we can teach people how to operate Peyronie's disease. Next slide, please. I have no disclosures. So the timeline. Why is it important for us to train people with models? Since before Christ, the human anatomy studies are using animal models, and the primates and porcines, they are described by Galen as the most similar anatomy with the humans. In the Renaissance, human bodies start to be dissected by physicians, sculptors, and anatomists. You can see how the sculpture and the art evolved with the dissection. And you can see, for example, if you look in Rome, you have statues like in the Fontana di Trevi, you have a biceps that has three heads. If you look after Michelangelo, you can see that Michelangelo was perfect doing the anatomy. In the industrial areas, animal models for surgeries start to be used even more frequently because right now we have anesthesia and we have some already the new knowledge about how to clean, how to keep asepsis and antisepsis, and simulations start to be using. In the current area, we have like plasters and low and high fidelity mannequins and virtual models. Next slide, please. And if you go back and put we are talking about simulation Peyronie's disease. If you go there and you look in the PubMed, you can see a lot of articles published about that. I did this PubMed in about 3 weeks ago and showed 59 items. However, if you go back next, you will see that if you look like step by step, you only will find like 4 articles that they are interest that really shows some kind of models that looking for they're really talking about like simulation and surgery. Next slide, please. So, and what is the rationale about having like a surgery simulator for Peyronie's disease? The literature estimates that Peyronie's disease prevalence goes between 0.5 to 13%, okay? So there's an article that was published using a KN database with 16,000 men over 18 years old. And from this, only about like 3.65% had Peyronie's disease. And from this, only 283 were selected to answer the second round of questions. From this, 128 saw the doctor, and from this 128, only 16 had surgery, okay? So you need to think that in the 16,000 men pool, okay, if you count that, only 4.48 had surgery with grafting. So the number of the patients who have surgery, they are very short. And so it's very hard to train someone for Peyronie's disease, for surgery for Peyronie's disease, if you don't have a simulator to train our residents and the surgeons who wants to be. The other article that was made a little bit more, with a little bit more criteria, it was a high center of Peyronie's disease surgeries, and they studied this patient, the number of the time frame about 6 years, okay? From the 1483 individuals assessed, only 1263 were meet the inclusion criteria, and from this, only 35% had surgical intervention. This is in 6 years, okay? The ones who didn't have ED, about 30% had plaque incision and grafting, and the 7.6% they had application. Okay, when I put these numbers in round in red, it means that I'm counting about the patients who had like Peyronie's disease. Okay, so I'm counting the number will be the denominator will be 1263. And the other ones that went to with IPP, about 9.68%, they went for an IPP. And from this, you will see that the modeling is part of the procedure. Some of them will have application and some of them will be grafting as well. But you can see that these numbers are very low. So that's very important for us to have some way to train people to learn how to perform that, because we don't have a lot of patients who needs this kind of surgery. Next, please. So this was a model that was created by Dr. Miranda in Brazil, and he created and validated the first low fidelity and cheap model for Peyronie's disease. This was published and validated. Next, please. So this was the validation, and this is me performing a procedure. You can see like the video, and I'm performing a procedure in the model, because we are doing another article like to you will see in the future what we're doing that. But this is how you use the model to operate, and that's good because it's easy to move around, and you can see you can perform the surgery using very easy, very like regular material that you have in the OR. And so the first 3 pictures in the top here, it's when we are validating the procedure in Brazil in the University of São Paulo. That was the first course we did. And the other ones in the low is when I went to Egypt, and we are creating like a second generation of model that is here, as you can see, to improve a little bit the experience for the surgery. Next model, next slide, please. So this was the article that was published, and this is how we validate the article, okay? You can see here we use the Likert score to create, and despite being a low fidelity model, it was a realistic design, because what you want to see in these models are the curvature, okay? The anatomy, it shows how you can feel. The question is how you can feel the anatomy, if you feel that is realistic when you make the incision, if you can notice that the corporal cavernous was good, the texture of the model, the curvature measurement. So how you're going to curve, how you can make the measurements. We are teaching people how to do the measurements. If the incision of the tunica albuginea was easy to be done, the preparation of the graft was good, and the suturing the graft and tunica albuginea. You can see that most of the answers were 4 or 5. So the students, they like it. And this test was done validated by using surgeons, residents, surgeons with experience, and surgeons without experience as well. Next slide, please. So the global difficulty in usability, most of the people, most of the trainees, they thought that it was kind of difficult, but it's expected that because surgery for Peyronie's disease, especially for grafting, is very hard to be done. So it's difficult anyway. Usability was good. Most of the people like the way to use it. You could see me when I was operating, that was easy. You can just twist the base and it will help you to make the incisions. Okay. And the overall experience, most of the trainees, they enjoy and they like. Next slide, please. And the validity. So we asked if people think it was important to have a Peyronie's disease simulator for training. Most of the trainees, they agreed with that. If the simulation of the disease was important and essential for patient safety. You look at already by the numbers that we don't have a lot of patients to have surgery to be done. So it's important for us to train people about that. Even in centers with high volume, in 6 years, they only had like 400 patients to have surgery. And from these patients, most of them, they didn't go for grafting or an IPP. The plaque incision graft, it was effective. Sorry, plaque incision and graft for Peyronie's disease is an effective method for treatment or training. It's a must. Yes, so it means we don't have a lot of, as I said before, we don't have a lot of patients needing surgery, or they need surgery, but they don't arrive to us. So it's important to have a model that people can train. After performing the simulation, the 3D model, does the participant feels more confident to perform a surgery? They said yes. And should the model be implemented as part of the surgeon training for perform plaque incision and grafting? You can see that numbers 4 and 5. So everybody agree, all the participants, they agree that it's important to have some kind of a way to training before go for a surgery. Next slide, please. So, and this was the publication that was validating. It was published in the Sexual Medicine. And next, please. And what did we learn? Okay, we used these models like to compare techniques, surgical techniques, and see how big will be the gap when you make the incision. The most common technique used for the incision and grafting is the double Y. So we use the double Y and we compare with another technique that was published in 2012. That was the eye grafter. And we prove it with this model we use 6 surgeons with experience, and we ask them to operate 2 models with each technique. And we show it that the spread between the area with the double Y was bigger than with the eye grafter. So we could compare techniques and see which technique will give us smaller size of grafting, which makes difference for the ED if you are performing a surgery in a patient who doesn't have ED with Peyronie's disease. And this was presented at the ISSM 2023. And we also presented that here at the US in the South Central section. Next, please. And this is how we print. Okay, you put the spool and you start like printing, and this is the next step. This is the one that I'm trying like to develop right now. The idea is be able like to put the model, and we will be a cheap model. So patients, so the surgeons will be able to use like a regular 3D printer, and that not super expensive to be bought. And you can buy spools that cost about like $30 with 500 grams of material. And when you print, these spools are able like to print about 100 models. So each model, except for the printer, will cost about like 25 cents to 50 to 32 cents of dollar to be printed. And the other things that I already noticed is this, I learned with time. You can see that I have like a dual extruder here, and didn't work that well. I thought that dual extruder will make my life easier. Although when they change the extruders, it makes harder for printing. So right now I'm printing everything with one extruder only. So you can even buy a cheaper 3D printer to print the models. And the plan is, as soon as I'm able to validate this model, is to put in the internet, and you can download and just print in your own 3D printer. So it can be spread all over the world without any cost for the surgeon or for the trainees, because this will be open source. Next. Next slide. Okay, and we are planning to perform a course in the SMS World Congress. Okay, it is a official pre-meeting event, will be happening September the 25th, 2024 at the Hotel Windsor. It's the same hotel of the meeting. So you are all invited to join us to the course and have a hands-on model of Peyronie's disease. Next. Well, what's the take-home messages? Peyronie's disease has a prevalence about 0.5 to 13% worldwide. Medicine has been using simulation models since the antiquity. For patients diagnosed with Peyronie's disease, between 12.5 to 35.5% will go for surgical treatment. From this, about 15 to 35% will have a grafting procedure. So it is 15 to 35 from this 12.5 from 35.5%. So it's much less patients than, it's not as much patients that they will have the procedure for grafting. Trainees believe that the training model is a good way to prepare for the surgery, and the 3D models may be used to compare current Peyronie's disease surgical techniques. You need this kind of low model training, low fidelity models. They are used by other professions as well. In the past, if you look how the pilots learn how to fly, you will see that they use very low real command. Right now, it's easy because you have the computer and the virtual reality that makes everything easier to be done. But if you go back in the past, we will see that the simulators, they used to have low fidelity. Okay, next. Next slide. Okay, I would like to thank you and like the organization, appreciate the organization, the invitation for the speaking. Next.
Okay, thank you, Bruno. Thank you, Ahmed. They were really fantastic talks, and I mean, this is just the beginning, isn't it? There was a couple of questions in the chat which I thought I'd do before I've got my own questions. Ahmed, do you all the sort of prostheses that you use? The companies give you those prostheses and you keep them, or I mean, how do you're going around the country using it? You just keep all the old prostheses, wash them, and use them again?
Yeah, so everything used in this model is reusable since it's non-biohazardous. So we have research agreements or grants from several institutions, the two most common industries that make these, and we have procured from them some of their prostheses that enable us actually to do this. Some of them were working actually on not standardizing the size, because right now the size is standardized. And what we've done is we're working with a certain industry to actually make different sizes so that sizing and measurement of the prostheses, which is an essential step, becomes very relevant at this point. So it's not just one size. We're also working on advancements like, fibrosed corpora, where there's an infection occurred and you remove the prostheses, a corpora in which there was perforation, different types of, I would say, situations or scenarios that would allow for advanced training on the spot.
Yeah. And are those models, because there's a few models now, they're sort of going through it in the European school, where you can actually just take the, you've got because yours, you've got a very nice base plate with, the put in the reservoir and the vessels, but you could perhaps, I've seen some where you can actually take the penis off and then fit a new penis in there with a different condition. Is that something?
Yeah, we've done that. We've done that for priapism training. We use the same base, and for interns or junior residents that need to train on priapism, we've actually created that replacement where you can just take the penis out and put it in. We are working towards a modular design that allows you to either, use a certain component of the model or the entire model itself. But the true value of this is actually just looking at full procedural simulation. So as you've seen, this is not a model that would use for early career or junior or medical students. This is somebody that really wants to advance their skills in penile prosthesis placement.
Okay. There's one here from John Mulcahy. The cost of each gel model. That's really to both of you, really.
Yeah, so we are not low cost. Yes, look, the material is incredibly cheap. The know-how is patented. The labor it takes to produce, these are like your, custom-made models that are made one piece at a time. And so they are very expensive and involve a lot of man hours. What I can tell you is the more you make, the less cost per model. And usually we do this through industry grants and then supply them to the end users. It's very expensive for a user to buy this.
Yeah, I think you need to get the companies to do courses and sponsor it by buying the models from you. I think that's I've done that before. It's a really good way.
That's the way we work to make this work, because it's very expensive for the end consumer.
I mean, each model, though, I know we're talking about penile prosthesis here, and obviously you've got a sphincter one as well. But can the same model be used, the same, we're talking about cost here, the same model be used, let's say, for a bit of Peyronie surgery or a bit of urethroplasty? Because I've used it, and it's a very nice urethra. It's really realistic. Have you sort of done that?
That's a great question, because when we built the AUS model, we actually dubbed it as a urethroplasty model, same exact thing, so that it would work for both. We're modifying our penile prosthesis to be, penis out, penis in, and then you can use it for Peyronie's disease, you can use it for grafts, you can use it for different approaches and different procedures.
Yeah. There's a question here for you, Bruno, about does every patient have his own model? That's every delegate, I guess, in the training have his own model. I guess it's quite cheap, so the answer must be yes to that, is it?
Well, actually, no, because what I did, I create like a model that is like a standard model. So all the models have 60-degree curvature. It's just like for training. I was working to create like a 3D model and work around with the cell phone. They have like a app that you can go around and create a 3D model and try to print. But it was kind of a difficult task to do it, because the 3D scanner and the cell phone, the LiDAR technology didn't work as well. You need like to use a lot of memory of your cell phone. The cell phones was not able to recreate that. It was a hard way to do it.
Yeah.
But the goal of this this training is not be as realistic as Dr. Ahmed has in his model. It's kind of like an introduction how you're going to learn. You're going to learn the steps of the surgery through the model. So when you know at least how you're going to make the measurements, because this is very important when you're performing a Peyronie's disease. You need to know where the curvature starts, where the curvature ends. So you can make the calculations and perform the calculations the correct way and make the incision in the right spot, make the marks where you need to make the incisions. This is a difficult thing to learn when you're having a human being. First, because it's hard to put like the methylene blue or make the marks in the wet tissue, in the live tissue. So if you don't have like this introductory training, it will be much harder for you to learn in the real step. You train residents, I train residents, Dr. Ahmed trained residents, Omer trained residents. We all know how hard it is for them to understand a complex surgery like a grafting in Peyronie's disease. So this model is like an introductory way to get there. Actually, I think this model will work good if we start someone with this model, they learn how to do it. And after that, they go for a high fidelity simulation as Dr. Ahmed. The goal with this one is make it cheaper and easier for anyone. A person in India, if they have a 3D printer, they will download the file and they will print that and they can see how it is. And as Dr. Ahmed did, we can use like a 3D virtual conference and tell them, hey, that's how we're going to do. You're going to cut here, you're going to do like this, you're going to do like that. And we'll teach them how to make the correct measurements and work on that. So this is not a high fidelity. So I'm not doing anything with a patient. Can we make like curvatures more complex? Yes, we can. We can make like a curvature with 70 degrees, with a 90 degrees. We can make one with a biplanar curvature as well to teach people how to make the incisions. That's possible, but right now this is a kind of way of standardize people to learn how to make it work.
And does the model have a neurovascular bundle which you have to raise? Because that's the hardest part, isn't it, of grafting?
That's actually what I'm working now with this new model. That's what I'm trying to do, is create a way to make the vascular bundle to do it. The other model that was created by Dr. Miranda, he put like a plastic, very hard plastic thing that will simulate when you're doing the suture, the difficulty that the vascular bundle does, but you don't need to dissect. Actually, I had an idea and I'm working on it, like to be, so the patients, so the trainees, they need to dissect the neurovascular bundle to be able to move and perform the surgery. Yeah. I'm actually working on it right now.
Do you think the days, well, both of you really, do you think the days of cadavers are finished now? I mean, because, you know, all the sort of legality around it and the cost, and, you know, you can't choose where you're going to do your course because you have to be in an anatomy lab, for example. I mean, do you think this is going to take over from cadavers and cadavers will be a thing of the past?
Yeah, I would say for sure. That's why we did the head-to-head comparison, because it was very difficult for people to really absorb that this is very similar to a cadaver. And until they did a head-to-head comparison and did the cadaver and then went back and did the hydrogel, they saw that difference. And one thing they liked actually was, you know, the cadaver, it's different. One of it could be fibrosed, one of it could have bad tissue, one of it could have good tissue. But the beauty is that our model is standard. It's the same exact thing every time. And in the beginning, when you're training, you need repetitive practice. I think industry is also going through a period, who is the main sponsors of these courses, where there is a significant amount of cost crunch that is happening for their educational budgets are going down significantly every year. And so as a result, like you had mentioned, they don't need to go to a specialized lab. They don't need to take people from a conference, put them on a bus, and then take them somewhere else. They can do it right there in the hotel room. We've done robotic courses using these models in a hotel room next to the main hall. And that way you have the capacity of not only having the convenience of cost for the place, but also having the convenience of the participants are right there and you can enroll as many. So a lot of the courses that I run using these models are concurrent courses. They're not from 9 to 10. No, they run in tandem with the main session. And that way you have a lot more participants that are able to learn. and the experts also rotate through it. So it is a significantly better way of convenient way of teaching. I would actually like to say that it's even better. And it's more, a lot of people just are risk averse to cadaver. Cadavers for them mean infection, mean disease. They're always afraid when they're handling needles around them. This type of hydrogel model gives them truly the safety and the relaxation that they're never going to contract disease from it.
Yeah, I agree. It's so much easier. You could just have it in a normal classroom, and you haven't got the chief of anatomy going around asking you what to do and if you got a license for this and that. So it's much easier, and therefore more people will be trained. I mean, make life easy, and then more people will come forward.
I think that's actually the goal that we have in Create Simulators. And as Dr. Ahmed said, it's much easier. You don't have any problems if you, for some reason, you hit yourself with a needle.
Yeah,
people don't get like so sad about that. And everything, and I think as realistic as Dr. Ahmed model is, you don't see any, there is no difference in the tissue when you feel, and they even bleed. So that's something that will perform much better than have a cadaver. I think really this is the future.
Yeah, I agree with that. Yeah. Omar, is there any questions that you want to ask?
Yeah, no, I want to really thank both of you really for wonderful really discussion. My question really just in line with the country to country differences. I mean, there are some countries who are actually forbidding using cadavers in their training. So having this hydrogel models can be really replace the cadaver need to train the next generation. So kudos to you, Ahmed, and also Bruno for leading the way in advancing the surgical training for our trainees. And my other comment is about the for Bruno actually about the printing. I mean, the way I see it, and just a comment is about the printing the patient his own like Peroni like cases before for the surgeons obviously and the trainee to do it or to practice on those like real patients basically. So if you have a very complex deformity, hourglassing or biplanar deformities, and you want to do surgery on them before going in, printing them for the patient to counsel them properly, even for the almost like a roadmap for surgeon before going in doing surgery. So are you thinking about as well? I mean, to print their patient their own pictures and in a 3D format?
Well, you need to think that what I'm creating is completely different what Dr. Ahmed is creating. Okay, Dr. Ahmed is creating like a very high fidelity that you look like a patient. So it will bleed, you're going to have blood, you will have to dissect, make the incision in the skin. What I'm creating is not that. What I'm creating is a way that you can practice the surgery after you already know how to do that. So you already know what you need to do to get to the corpora cavernosa. You're going to make an incision in the skin. You'll get there. You will find the corpora cavernosa. So what is the hardest part of learning for Peyronie's disease? Is how to measure the curvature, and is how to make the incisions and how to put the measurements in the right spot. So I'm not creating a high fidelity. My model is, there's a different goal than Dr. Ahmed model. So we can actually create a model for the patient. For if you have a patient for biplanar curvature, we can create a model like I measure in the clinic. The patient has a curvature 70 degrees dorsal, 30 degrees lateral. Can we create a model like that and training before the surgery? Yes, we can. But my goal is not training you all the steps of the surgery. My goal is training you how to make the incisions to perform the plaque incision and the grafting. I'm not training you how to perform the surgery since the beginning to the end, especially because who will perform this kind of surgeries? They already know how to operate a penile prosthesis. They already know how to get access to the penis. And this is actually the first initial part is like putting a penile prosthesis, a regular penile prosthesis, if you're doing a surgery like that. So you're going to dissect, you're going to deglove the penis, or you're going to advance a little bit more. You like to deglove the penis, but you will perform the surgery that you already are used to do. It's just getting like the hardest part, that is incise the plaque and put the graft. That's what is important. How are you going to keep the tension? How are you going to make this? So this is not a high fidelity, it's a low fidelity. So it's just you to learn like the most difficult part of the surgery that you don't know, you don't have a lot of experience doing that.
Thank you.
But also for experienced surgeons, I mean, we were all, you mobilize the neurovascular bundle, someone's trying to give an artificial erection, you're trying to guess where the line should be drawn and you cut, and how far should you go on one side, for example. And that's a grafting and a Nesbitt plication. You put in Alice's just to sort of work out where the teeth of the Alice's are. It would be fantastic if you could have, right, this patient needs his penis straightened, you do a model of that particular patient, and you say, right, this is what's going to happen in surgery. You're going to have a line cut across here, which is 5.2 centimeters from the corona. It needs to be this length, and that's the graft you need.
I agree with you. The problem is the kind of material that we use in 3D printers, okay? In this case here, I can show you a model that I have here. They are not super flexible anyway. And when you do that, when you're printing this, you need to think that when you make the incision, the penis will not going to open as easy to do. The other thing is the time that takes to print each of these models here. This takes like 2 hours to be printed. This one takes about like 2 hours and a half to be printed. Takes time to do that as well. I think like if we have a good technology of 3D scanners, like with more capacity, that will make it better. Anyway, when you're doing that, you're not doing the 3D scanner from the corporal cavernosa, you're doing just from the outside of the patient. So you still have like skin, and you need like to recreate something or have like a kind of software that is able to calculate everything to tell you how is the way that this thing needs to be printed. And we also know that after you release the neurovascular bundle, the curvature gets a little bit better because you are releasing all that scar tissue that is there. So things change. This is actually a model that we are planning just to teach people how to mark. And I know it's hard to keep the erection. That's why it's erected already. You don't need to keep it. It's the way like to teach people like the initial steps. So when they get to the surgery, they are not like completely, oh, this is the first time I'm doing that. I don't have anyone. I never see this thing being done before. So this is really like it's like the baby steps of the training. We need like more fidelity, high fidelity training to teach people how to go around, like, let's make the deglovement. Let's expose better the corporal cavernosa in this. But I can tell one thing, if I'm actually working on it, if I can put a neurovascular bundle here, that will help a lot in the dissection, and I'm working on it.
But also for Ahmed, I guess, I mean, we do all live surgery and semi-live surgery. I mean, if the models get really, really good, then live surgery is becoming perhaps a thing of the past as well. So
to demonstrate new techniques and demonstrate, kind of maneuvers without putting a patient at risk. That is, definitely that would be a very interesting way to look at it.
Yeah. Omar, would you like to have the last words?
Thanks, David. This has been wonderful, and we can go on discussing this wonderful innovation in surgical training. Thank you, David, for moderating. And really, the comments that Ahmed mentioned about how versatile this model is, you can run it tandemly with a conference, right, and next door in a hotel, and other things we do with the simulations is amazing. So thank you for all really insight into this, and we look forward to more work in this area. I know you both of you are working on optimizing your models, right? So at one point we will have centers where we just come in and train our trainees in these innovative simulations that you're building in the world of sexual medicine. So thank you again. Okay, I guess we are wrapping up to this webinar. I think there's no more question, David. I see the chat here. Yeah, so Lillian, can you put the last few slides of the webinar? And thank you again for both of you and David as well. So I'd like to announce.
Thank you, everyone. This was great.
Thank you.
Thank you very much for the invitation.
Thank you very much. Stay with us because we're running the last slide of the presentations or the last announcement. So Lillian, can you put, perfect. Okay. All right. So without further ado, really, it's been an honor to have the faculties and the moderators here today, and would like to announce the upcoming webinar. This is the Psychology, Sexual Medicine, and Cultural Sensitivities in Diverse Communities. It's a DEI lecture, and going to be held on May 29 between 1 p.m. and 2:15 UTC, and will be hosted by ISSM webinar faculty and speaker as well. So with that, I'd like to thank you again for a wonderful time and have a wonderful week, and we'll see you then. Take care.